Welcome to the deep dive. Today we are embarking on quite an intensive exploration. We're looking at one of the most complex, really vital systems in the human body, vision.
That's right. Our source material for this is mainly Chapter 32, which is just packed with detail. It lays out this incredibly thorough framework for understanding the visual system.
And it even gives us a little peek into Chapter 33, looking at smell and taste too.
It does, but Chapter 32 is the core. It covers, the structure, how it all works, how we assess it clinically.
And maybe most importantly, right, the huge range of disorders that can affect our eyes.
Exactly.
So our mission today, really drawing from the source, is to get a genuinely deep, applicable understanding. We want to dive in deep enough that, you feel like you're starting to think about this like the absolute pros in the field, really mastering this essential knowledge.
Yeah, the material takes us right from light hitting the eye, through all the processing, the muscles moving the eyes, then systematically into the clinical evaluation, and this huge spectrum of conditions. Everything from, minor irritations to things that really threaten sight.
Okay, let's jump straight in then. Let's start unpacking the fundamental design. The source calls vision supremely efficient for taking in information quickly and guiding how we act.
Think about just working down a busy street or trying to catch something thrown at you. It's instantaneous processing, guiding really complex actions.
So where does it begin? Yeah. Light entering the eye.
Right. First, it hits the cornea, that clear front part. Then it passes through the pupil and the lens. These two, the cornea and lens, they're the main focusing elements. They bend the light to form an image on the retina at the back.
And the retina itself is fascinating. The source says it's actually part of the brain.
Yeah, essentially brain tissue that migrated out to the periphery during development. Its job is absolutely critical to convert that light energy into electrical signals the brain understands.
And it does this using photoreceptors, rods and cones.
Exactly. And the numbers are really telling. We've got something like 100 million rods.
Wow.
Yeah, huge number. They're optimized for dim light, what we call scotopic vision.
And the cones?
Only about 5 million cones. They handle bright light photopic conditions, and they're responsible for color vision and that high-resolution detail we need for, say, reading.
So why the massive difference? 100 million versus 5 million.
Well, it speaks to evolutionary priorities, doesn't it? Having loads of rods gives us amazing sensitivity for detecting movement and just getting around in low light. Crucial for survival historically.
Makes sense.
While the cones, fewer in number, are packed into the area where we need that really sharp, detailed vision.
And that's the macula.
Precisely. The macula handles our central vision, maybe the central 10 degrees or so, and it's crammed with cones. Right in the very center of the macula is a little pit called the fovea.
Ah, the fovea.
And that contains only cones, no rods at all. That's where we get our absolute best visual acuity, our sharpest focus.
Okay, so light hits these rods and cones. What's the next step in this sort of mini brain?
Well, the photoreceptors do something pretty unusual. Instead of depolarizing like most neurons when stimulated, they actually hyperpolarize. They become more negatively charged in response to light.
Interesting.
Yeah, it's a bit backward compared to what you might expect.
Mm-hmm.
This initial signal then gets processed through this complex network of cells in the internuclear layer of the retina. You've got bipolar cells, amacrine cells, horizontal cells.
Like a little pre-processing step right there in the eye.
Exactly. It's refining and integrating the signals before they even leave the retina. All this information then converges onto the ganglion cells.
They're the output cells.
They are. They're the ones that translate these patterns of light and dark into action potentials, the electrical spikes that the rest of the nervous system uses. And the source gives a key figure, about 1 million ganglion cells in each retina.
So 1 million nerve fibers making up each optic nerve.
That's right. 1 million separate channels of visual data heading out from each eye.
Incredible. How do they get to the main visual areas in the brain?
So the axons from these ganglion cells sweep across the inner surface of the retina, forming what's called the nerve fiber layer. They all collect together and exit the eye at a spot called the optic disc.
The blind spot.
The physiological blind spot, exactly. Right. Because there are no photoreceptors there, just exiting axons. These axons bundle together to form the optic nerve, which then travels back towards the brain.
And they meet at that crucial junction, the optic chiasm.
Yes. At the chiasm, something really important happens. The fibers that come from the nasal, half closer to your nose of each retina, cross over to the opposite side of the brain.
But the temporal fibers don't cross.
Correct. The fibers from the temporal, half the side closer to your temple, stay on the same side. This partial crossing, or decussation, is key. It ensures that everything you see in your left visual field gets processed by the right side of your brain, and vice versa.
Okay, so after the chiasm, the pathway is called the optic tract.
Right. And most of the fibers in the optic tract head straight for the lateral geniculate body, or LGB. It's a part of the thalamus.
The brain's relay station.
Pretty much, yeah. A major relay and processing station for visual information. From the LGB, neurons send their axons via the optic radiations back to the primary visual cortex, which is located right at the back of the brain in the occipital lobe.
And that pathway, retina, LGB, cortex, that's for conscious sight.
That's the main pathway for conscious visual perception, yes. But it's not the only destination for signals from the retina.
Ah, okay. The source mentioned others.
It did. There are specialized types of ganglion cells that project to other areas, often for functions we're not consciously aware of. For example, some contain a special photopigment called melanopsin.
Melanopsin, what does that do?
These cells are particularly sensitive to ambient light levels. They project to areas involved in controlling the pupil's response to light and, really importantly, regulating our circadian rhythms, our internal body clock.
So they're seeing light but not really forming images for us.
Exactly. For the pupil reflex, these melanopsin cells send signals to the protectal nuclei in the midbrain. These then activate the Ettinger-Westphal nuclei, which control the parasympathetic nerves that constrict the pupil.
The pupillary light reflex pathway.
That's the one. Retinal signals also go to the superior colliculus, another midbrain structure, involved in orienting your eyes and head towards interesting things in your peripheral vision and controlling rapid eye movements.
And gaze stabilization.
Right. Input goes to the accessory optic system in the brainstem, which helps keep your gaze steady when your head moves, and mediates optokinetic reflexes, like when your eyes automatically follow stripes on a moving crane. It's a very parallel system, different pathways doing different jobs.
That gives us a great picture of the input side. But vision isn't passive, is it? We're constantly moving our eyes. So let's talk about the motor system.
Absolutely essential. We need to constantly rotate our eyes to place the image of whatever we want to see clearly, right onto that tiny fovea. This is called foveation. Basically, yes. And since the fovea is so small, we need incredibly precise and constant eye movements to keep the target there, especially as we look around or move our head.
And this is done by the 6 extraocular muscles attached to each eye.
Correct. And these muscles get their instructions from motor neurons located in 3 specific cranial nerve nuclei in the brainstem.
Let's see. Oculomotor.
CN3 in the midbrain. That controls most of them.
Trochlear.
CNIV, also midbrain, just controls the superior oblique muscle.
And abducens.
CNDI, down in the pons, controls the lateral rectus, the muscle that moves the eye outwards.
How does the brain coordinate all of this, getting both eyes to track smoothly or jump quickly between points?
Well, the source highlights these really complex coordination circuits right within the brainstem and the pons and midbrain. These circuits generate the different types of eye movements we need. Smooth pursuit for tracking moving objects, saccades for those quick jumps and fixation, and the vestibulo-ocular reflexes that keep your vision stable when your head moves.
And control comes from higher up, too, from the cortex.
Yes, absolutely. Large areas in the frontal cortex, the frontal eye fields, and the parieto-occipital cortex send signals down to these brainstem centers. This is often called supranuclear control. Think of it like the cortex deciding where to look, and the brainstem figuring out the exact muscle commands to get the eyes there. It's a really sophisticated hierarchy.
Okay, that's machinery. Incredible stuff. Now, let's shift to something really crucial for professionals trying to master this.
Yeah.
How do we actually assess the system clinically? The source material lays out a very systematic approach.
Yeah, this is where we connect the theory to practice. The very first thing to think about when someone says their vision is reduced is their refractive state.
Meaning simply, do they need glasses? Is the eye just not focusing light properly?
Exactly. Is it a simple refractive error? The source defines emmetropia as perfect focus. Then you have the common errors, myopia or nearsightedness, where the eye is usually a bit too long, so light focuses in front of the retina. Hyperopia or farsightedness, where the eye is typically too short, focusing light theoretically behind the retina. And astigmatism, where the cornea isn't perfectly spherical, so light focuses differently in different meridians.
And these are usually fixed with glasses, contacts, or surgery like LASIK or PRK.
Right. And then there's presbyopia. That's the age-related thing where the lens gets stiffer, making it hard to focus up close. That's why people start needing reading glasses usually in their 40s or 50s.
The source mentions an interesting systemic link here, sudden myopia.
Yeah, in poorly controlled diabetes, high blood sugar can cause the lens to swell, changing its refractive power and making someone suddenly more nearsighted. It's a classic example of how eye signs can reflect systemic health.
And the pinhole test. That's a neat trick.
It's a great quick screen. If someone's vision improves significantly when they look through a tiny pinhole, it strongly suggests their blurriness is due to uncorrected refractive error. The pinhole works by blocking out the peripheral unfocused light rays, only letting the central, more focused rays through.
So once you've considered refraction, the next big thing is visual acuity.
Right. Measuring how clearly someone sees. Usually done with a Snellen chart for distance vision.
Yeah.
The standard eye chart at 20 feet or 6 meters, and a Rosenbaum card for near vision, held at about 14 inches.
20/20 or 66 being the standard normal.
Exactly. And it's vital to test acuity with the patient wearing their best correction glasses or contacts, including reading glasses, for the near test if they have presbyopia.
And if vision is really poor,
then we have to document it differently. We might record it as counts fingers at a certain distance, or just hand motions, or light perception if they can only tell if a light is on or off, or no light perception if they can't even see a bright light.
The source also gives the definition for legal blindness.
Yes, in the U.S., that's typically defined as best corrected visual acuity of 660 or 2200, or worse in the better eye, or if their visual field is restricted to 20 degrees or less.
And driving standards.
They vary, but often something like 612 or 2040 is required in the better eye. And a really important point for clinical practice. Someone with a homonymous hemianopia, where they've lost half of their visual field in both eyes, even if their acuity is 20/20 in the remaining field, is generally considered unsafe to drive.
Okay, let's talk pupils. They seem simple, but the source shows they're packed with diagnostic clues.
Absolutely crucial. You need to test them one at a time, in dim light if possible, checking their size, shape, and how they react to light. The source mentions the common acronym PEER-RLA.
Pupils equal, round, react to light, accommodation.
Right, but it makes a good point. Checking the A for accommodation, the near response, isn't always essential if the reaction to light is nice and brisk. However, if the light reaction is poor or absent, then checking the near response becomes really important.
Because that can reveal light near dissociation.
Exactly. That's where the pupils constrict okay when focusing on something close, but react sluggishly or not at all to direct light. The classic cause is the Argyll-Robertson pupil, often linked to neurosyphilis, but you also see it with lesions in the dorsal midbrain, like impairment nose syndrome, or sometimes after aberrant regeneration following a third nerve palsy, or with an 80s tonic pupil.
And the pupil reaction also reflects the health of the optic nerve or retina itself, right?
Definitely. An eye that has no light perception won't have any pupillary response to light shown in it. But what's really useful clinically is when there's partial damage to the optic nerve or retina. The signal about light intensity sent back to the brain is weaker from that damaged eye.
And that leads to the RAPD.
The relative afferent pupillary defect, yes, also known as the Marcus Gunn pupil.
And you pick this up with the swinging flashlight test.
Precisely, as shown in figure 32-2. You swing a bright light back and forth between the two eyes, watching the pupils. Normally, when you swing the light from, say, IA to IB, the pupils in both eyes should either constrict further or stay constricted. But if IB has an RAPD, the signal is weaker. Right. So when you swing the light from the healthy IA to the damaged IB, the weaker signal from B actually causes both pupils to dilate slightly because they're reacting less strongly than they were to the light in IA. It's a relative defect comparing the input from the two eyes. It's a fantastic objective sign of optic nerve disease, like optic neuritis, even if the back of the eye looks normal.
But it won't show up if both eyes are equally bad.
Correct, because it's all about the comparison between the two afferent pathways. If both are equally damaged, there's no relative difference to detect with a swinging light.
What about anisocoria pupils of different sizes?
A small difference, maybe up to 0.5 millimeter, can be totally normal. That's physiologic anisocoria, as long as the difference stays the same in both bright and dim light. But if the difference gets larger in dim light,
the smaller pupil is the problem.
Yes, that points to a problem with the sympathetic nervous system supply to the iris dilator muscle. That's characteristic of Horner syndrome.
The triad, pearlpitosis, droopy eyelid, meiosis, small pupil, and anhidrosis, less sweating. Though the source says anhidrosis isn't always there.
Often it isn't, or it's hard to detect. Horners can be caused by serious things affecting the sympathetic chain anywhere from the brainstem down through the neck and chest, like stroke, carotid dissection, or a tumor pressing on the nerves. But frustratingly, it's often idiopathic, meaning we don't find a specific cause. There's a test using aproclonidine eye drops that can help confirm Horners. The denervated pupil becomes hypersensitive and dilates paradoxically.
And if the pupil difference gets larger in bright light,
Then the larger pupil is the abnormal one. This suggests a problem with the parasympathetic pathway controlling the iris sphincter muscle, the one that constricts the pupil. The immediate concern is damage to the oculomotor nerve, CN3, because the pupil fibers travel with it. But you'd look for other signs of CN3 palsy, like limited eye movements or ptosis, to confirm that.
an acutely dilated pupil can also happen from damage within the orbit.
Yes, damage to the ciliary ganglion, maybe from infection, trauma, or ischemia, can cause acute dilation or mydriasis. This can lead to a tonic pupil.
What's a tonic pupil?
It's a pupil that reacts very poorly, if at all, to light. But often, it still constricts reasonably well when a person focuses on something that's part of the light-near dissociation, and then it retilates very, very slowly afterwards. The most common cause is Adie's syndrome, which is usually benign, often affects young women, and is frequently associated with absent deep tendon reflexes. It's thought to be a mild form of dysautonomia. It can sometimes be linked to other systemic conditions, too. A dilute pilocarpine test helps confirm it. The hypersensitive tonic pupil constricts strongly to a very weak 0.125% solution.
And we shouldn't forget about drugs causing pupil changes.
Absolutely. Accidental exposure to anticholinergic eye drops, think atropine or scopolamine, will cause a widely dilated pupil that doesn't react to light or even strong constricting drops. The source mentions Gardner's pupil from handling plants containing similar alkaloids. Systemically, narcotics typically cause small pupils, miosis, while many systemic anticholinergics cause dilation, mydriasis. Even some glaucoma drops, like pilocarpine, work by causing miosis. And of course, a slit lamp exam is needed to rule out direct physical causes like trauma or inflammation affecting the iris itself.
Okay, moving on. Eye movements and alignment. So critical for seeing single, clear images.
Right. We test versions first, watching both eyes move together as they track a target in all directions of gaze. We're looking for smooth, symmetric, full movements without any nystagmus, which is that involuntary jiggling. We also check saccades, those quick refixating eye jumps, which should be fast and accurate.
A quick check for alignment is the corneal light reflex.
Yeah, you shine a pen light at the eyes from straight ahead. If the eyes are aligned, the reflection should appear centered in both pupils. But it's not very sensitive. The cover test is much better for picking up even small misalignments or heterotropias.
How does the cover test work exactly?
The patient focuses on a target, say, to cross the room. You cover one eye, maybe the right eye, and you carefully watch the left eye, the uncovered one. If the left eye has to move to pick up fixation when the right eye is covered, it means it wasn't pointing directly at the target. Initially, it was misaligned. If the left eye doesn't move, it was already fixating properly. Then you repeat the process, covering the left eye and watching the right. If neither eye moves when the other is covered, they're aligned. That's orthotropia. It's really important because even small misalignments that aren't obvious can cause double vision or diplopia.
The source mentions doing it with head tilts, too.
Yes, sometimes a misalignment only becomes apparent, or the patient only experiences diplopia when their head is tilted or turned in a certain way. So you might need to perform the cover test in those positions as well. The size of the deviation can actually be measured using prisms, and depending on the cause and size, misalignment might be managed with temporary stick-on prisms, Fresnel prisms, prisms built into glasses, or sometimes eye muscle surgery.
What about stereopsis, our 3D vision?
That relies on having two eyes working together and the brain fusing the slightly different images from each eye, processing that retinal disparity. Stereoacuity measures how well someone can do this, usually using special polarized glasses and targets designed to present these small disparities. A normal threshold is around 40 seconds of arc. If someone achieves that, it pretty much guarantees their eyes are aligned and vision is good in both. Impaired vision or misalignment leads to much worse scores. Random dot stereograms are good screening tools, especially for strabismus in kids, because they don't have any monocular cues to cheat with.
Color vision next. Move to the cones.
Yep, the three types. Red sensitive, around 560 millimeter, green sensitive, 530 millimeters, and blue sensitive, 430 millimeter. The genes for red and green pigments are on the X chromosome, which is why congenital red-green color blindness is much more common in men, about 8%, because they only have one X chromosome. Blue cone defects are on chromosome 7 and much rarer.
How do we test for it?
Formal testing uses devices where the person tries to match colors. This can distinguish between anomalous trichromats, who have all three cone types but one pigment is faulty, impairing color discrimination, and dichromats, who are missing one cone type entirely. Screening is often done with Ishihara plates, those plates with numbers made of colored dots that are hidden from people with red-green defects. Usually we just screen boys in school.
Can color vision problems be acquired later in life?
Yes, definitely. Acquired color vision defects often point towards disease of the macula or the optic nerve. For instance, patients recovering from optic neuritis often complain that colors look washed out or desaturated in the affected eye. And damage to specific areas of the visual cortex can cause really profound color issues, like cerebral achromatopsia, where the person sees the world only in shades of gray that's usually from bilateral occipital strokes, or color anomia, where they can discriminate colors but can't name them, often from a stroke in the dominant occipital lobe.
Visual fields. This sounds like a really powerful tool for localizing problems.
It really is. Mapping out a person's visual field, the entire area they can see while looking straight ahead, can help pinpoint where a lesion might be along the visual pathway, all the way from the retina back to the occipital cortex. Figure 32-3 in the source material is key here. While just wiggling fingers in the periphery, confrontation testing, is a quick screen, quantitative perimetry using computer-driven machines is much more sensitive.
How do those machines work?
They present small spots of light of varying brightness at different locations in the visual field, and the patient clicks a button when they see one. This maps out the threshold of light sensitivity across the field, generating these detailed printouts. They're excellent for detecting subtle blind spots or scotomas, and absolutely essential for tracking progression in diseases like glaucoma or pseudotumor cerebri. And the key skill is interpreting the pattern of field loss. Exactly. The fundamental question is the lesion pre-chiasmal, retina or optic nerve, chiasmal or post-chiasmal, optic tract, LGB, radiations, cortex? A defect confined strictly to one eye has to be pre-chiasmal.
Okay, so pre-chiasmal, what kind of patterns do you see?
Well, if it's a retinal lesion, the scotoma corresponds optically to the damaged area. Remember, the image is inverted and reversed. So damage in the superior nasal retina causes a defect in the inferior temporal field. Damage right in the macula causes a central scotoma, a blind spot right in the middle of their vision. Big 32-3B?
And optic nerve damage gives different patterns.
Yes, depending on which bundles of nerve fibers are affected. Glaucoma is the classic example. It often preferentially damages the fibers entering the supratemporal and inferotemporal disc, creating these characteristic arcuate scotomas. They look like a curved sword or scimitar, arching from the blind spot around the central fixation point towards the horizontal midline. This pattern perfectly mirrors the way those nerve fibers are arranged in the retina. Other optic nerve conditions like optic neuritis or ischemic optic neuropathy can also cause these nerve fiber bundle defects.
What if a whole half of the nerve is damaged?
Damage to the entire upper or lower pole of the optic disc can cause an altitudinal field defect, respecting the horizontal meridian. That's typical for ischemic optic neuropathy or a major retinal vascular occlusion.
And the secocentral scotoma?
That involves damage to the papillomacular bundle, the fibers running directly from the macula to the optic disc. So the scotoma covers both the central fixation area and the physiological blind spot, figure 32-3E. Later on, you often see temporal pallor of the optic disc with this. It's seen in optic neuritis, nutritional or toxic neuropathies, Leber's hereditary optic neuropathy, and sometimes compressive lesions. Distinguishing true temporal pallor from just normal variation can be tricky, though. Pallor of the nasal rim is usually a clearer sign of optic atrophy. Oh, and figure 32-3F shows the enlarged blind spots and peripheral constriction you see with papilledema.
Okay, now what about lesions at the optic chiasm?
This is where those nasal retinal fibers cross. Lesions here, typically compressive masses from the pituitary gland below or meningiomas around it, tend to squeeze these crossing fibers more than the uncrossed temporal fibers. The classic result is a bitemporal hemianopia loss of the temporal outer half of the visual field in both eyes.
Can lesions just before the chiasm cause crossing fiber signs too?
Yes. A lesion pressing on the very end of one optic nerve, just as it joins the chiasm, can damage that nerve and catch the crossing fibers from the inferior nasal part of the other eye as they loop forward slightly, Wilbrand's knee. This causes a junctional scotoma, fig 32-3G typically, signs of optic neuropathy in one eye, plus a field cut, often superior temporal, in the other eye.
Bitemporal hemianopia sounds like it would be obvious to the patient.
You'd think so, but the source points out that patients often don't notice it initially because it affects their peripheral vision. They might bump into things on the sides, It often gets picked up incidentally during testing, especially if you test each eye separately.
Right. Now, lictions behind the chiasm in the optic tract, LGB radiations or cortex.
These all cause homonymous field defects. Homonymous means the defect is on the same side in both eyes. So, a left homonymous hemianopia means the patient has lost the entire left half of their visual world. That's the temporal field of the right eye and the nasal field of the left eye. Visual acuity, the ability to see detail within the remaining field, is usually preserved in each eye, but reading can become very difficult because they only see half a word or half a line at a time. Pinpointing the exact location along this postchiasmal pathway just from the field defect can be tricky.
Are there any clues in the defect pattern itself?
Sometimes. Lesions in the optic radiations, if incomplete, often cause defects that don't perfectly match in shape or density between the two eyes. We call that incongruous. A lesion in the temporal lobe hitting Meyer's loop, that bundle of radiation fibers that loops forward, typically causes a pie-in-the-sky defect, a superior quadrantic homonymous hemianopia. A lesion higher up in the parietal lobe affecting the radiations tends to cause an inferior quadrantic homonymous hemianopia. Lesions right in the primary visual cortex, often from a stroke affecting the posterior cerebral artery, usually cause very dense, incongruous, well-matched hemianopic defects.
What if the whole occipital lobe is affected by a stroke?
That usually causes a complete homonymous hemianopia. However, sometimes the very central part of the vision, corresponding to the macula, is spared. This macular sparing might happen because the very back tip of the occipital lobe, where the macula projects, sometimes gets blood supply from the middle cerebral artery as well.
And bilateral occipital damage.
If both occipital lobes are severely damaged, it results in cortical blindness. The person can't see, but crucially, their pupils still react normally to light, and the eyes themselves look perfectly healthy on fundus exam. That helps distinguish it from blindness caused by problems in the eyes or optic nerves.
The source mentions rehabilitation briefly. Does it work?
Well, computer-based therapies aiming to expand a lost field haven't really held up under rigorous testing. It seems they mostly train people to scan better with their remaining vision, rather than truly recovering the damaged brain tissue's function. Unfortunately, for permanent brain damage causing field loss, there's no effective treatment to restore the vision itself.
That systematic approach using visual fields is incredibly powerful. Okay, let's switch gears and tackle some common clinical scenarios, starting with the red or painful eye. Very common complaint.
Extremely common. And the source gives a good rundown of things to consider. Corneal abrasions are right up there.
Best seen with that fluorescein dye under blue light.
Exactly. The dye stains the area where the surface epithelium is missing, and it glows bright yellow or green under cobalt blue light. It's really important to check for any hidden foreign bodies, especially by averting flipping the upper eyelid. If there is one, you remove it gently, maybe with a moist cotton swab or irrigation.
Treatment.
Usually antibiotic ointment to prevent infection. A patch is sometimes used for larger abrasions to help comfort, but isn't always necessary. Cycloplegic drops, like cyclopentolate, can help relieve pain by relaxing the ciliary muscle spasm. And you'd want to re-examine the eye the next day to make sure it's healing.
Subconjunctival hemorrhage looks dramatic, but is usually benign.
Very dramatic. Bright red blood under the clear conjunctiva covering the white sclera. But vision is completely unaffected, and it resolves by itself over a week or two, like a bruise. It can happen spontaneously, maybe with coughing or straining, or from minor trauma or eye rubbing.
Yeah.
It rarely signals an underlying bleeding problem.
What about pinguecula and pterygium? Those sound similar.
They are. A pinguecula is a small, yellowish, slightly raised bump on the conjunctiva, usually on the nasal side, common in people with lots of sun exposure. It's mostly harmless unless it gets inflamed. Pingueculitis. A pterygium looks similar initially, but it's actually growing across the edge of the cornea, the limbus. It might need surgical removal if it causes irritation, affects vision by growing towards the pupil, or induces astigmatism, but they have a tendency to recur after removal.
Blepharitis, inflammation of the eyelids.
Very common, often associated with skin conditions like acne rosacea or seborrheic dermatitis, and frequently linked to Staphylococcus bacteria colonization on the lid margins. People get red, itchy, sometimes swollen eyelids, maybe with crusting or scaling along the lashes, and some discharge. Treatment is really focused on lid hygiene.
Warm compresses and scrubbing.
Yes, warm compresses help loosen crusts and express oil from the meibomian glands. Then gentle scrubbing of the lash margins, maybe with diluted baby shampoo or specific lid cleansers, helps remove debris and bacteria.
And styes and chalatzia relate to this.
They do. An external hordeolum, or stye, is an acute infection, usually staph, of one of the superficial glands near the lashes. An internal hordeolum is an infection deeper inside in a meibomian gland within the tarsal plate. Topical antibiotics like bacitracin polymyxin B ointment are often used. Sometimes, if there's significant meibomian gland inflammation, meibomitis, or severe blepharitis, systemic antibiotics like tetracyclines or azithromycin might be needed. A chalazion is different. It's a chronic, usually painless lump caused by a blocked meibomian gland leading to a sterile granuloma. Treatment for that is often incision and drainage or a steroid injection into the lesion. And a caution. Any eyelid lesion that looks ulcerative and doesn't heal should raise suspicion for malignancy, basal cell, or squamous cell carcinoma, or meibomian gland carcinoma.
Dacryocystitis that affects the tear drainage system.
Right, inflammation of the lacrimal sac, usually because the nasolacrimal duct is blocked. This causes excessive tearing, epiphora, and redness over the sac area near the nose. A key sign is pain, and often reflux of mucus or pus back out through the puncta, the little openings on the lid margin, when you press on the sac. Treatment involves antibiotics, both topical and systemic, and often requires procedures like probing, stenting, or surgery, dacryocystoinostomy DCR, to bypass the obstruction. The source also reminds us that eyelid malpositions, like entropion where the lid turns in or ectropion where it turns out, can also cause tearing and irritation.
Conjunctivitis, probably the condition most people think of for pink eye.
It's certainly the most common cause of a red, irritated eye overall. Usually there's minimal pain and vision is only slightly blurred, if at all. Viral conjunctivitis, often caused by adenovirus, is typically characterized by a watery discharge, maybe some mild foreign body sensation, and light sensitivity. Bacterial conjunctivitis tends to produce a thicker, more pus-like, mucopurulent discharge.
How is it treated?
Mild cases are often treated empirically with broad-spectrum topical antibiotic drops or ointment. Getting smears or cultures is usually reserved for very severe cases, newborns, or infections that aren't responding to initial treatment. And since it's often highly contagious, especially the viral forms, good hand washing and avoiding touching the eyes or sharing towels is really important for prevention.
Allergic conjunctivitis is different, though.
Very different and extremely common, often mistaken for infection. The hallmark symptom here is itching, significant itching, along with redness and tearing. Sometimes, on examining the inner surface of the eyelids, you can see these bumpy structures called papillae, sometimes described as cobblestone-like. This is common in people with other allergies, like hay fever or asthma.
Treatment for allergic conjunctivitis.
Cold compresses can help soothe the itching. Topical medications are the mainstay combination. Vasoconstrictor antihistamine drops, like olopatadine, are very effective. Mast cell stabilizers like cromolyn can help prevent symptoms if used regularly. Topical corticosteroids give dramatic relief, but carry significant risks with long-term use, glaucoma, cataracts, promoting infection, so they're used cautiously. Topical NSAIDs like ketorolac are a safer alternative for inflammation.
Keratoconjunctivitis sicca, dry eye.
Another very common cause of ocular irritation. Symptoms are typically burning, a gritty or foreign body sensation, redness, and sometimes light sensitivity. Mild cases might not show obvious signs on exam. Tear production can be measured with a Schirmer test using filter paper strips.
What causes dry eye?
Lots of things. Many common systemic medications can contribute: antihistamines, anticholinergics, some antidepressants, and antipsychotics. Disorders affecting the lacrimal glands, like Sjogren's syndrome or sarcoidosis. Radiation therapy that includes the orbits. And nerve damage affecting either corneal sensation, CNVB, or the parasympathetic nerves controlling tear production, CNV. Corneal anesthesia, where the corneal loses sensation, is particularly dangerous because the person doesn't feel injuries or dryness, which can lead to severe damage.
How is dry eye managed?
The first step is usually frequent use of artificial tears and lubricating ointments. If that's not enough, tiny plugs can be inserted into the puncta to block tear drainage, punctal occlusion, or the puncta can be permanently closed with cautery.
Keratitis, inflammation of the cornea itself. That sounds more serious.
It is. Keratitis is a definite threat to vision because it can lead to corneal scarring, which blocks light, or even perforation of the cornea. Causes are diverse: bacterial, viral, fungal, parasitic, like acanthamoeba, especially in contact lens wearers, and even severe vitamin A deficiency in some parts of the world. The source strongly emphasizes the risk associated with contact lenses. Never wear them if you have an active eye infection.
How do you tell superficial from deep keratitis?
Deeper ulcerative keratitis usually causes more significant visual loss, more pain, more light sensitivity, more redness, and often more discharge than superficial inflammation. On slit lamp examination, you look for disruption of the surface epithelium, infiltrates or abscesses within the corneal stroma, the main structural layer, and often an inflammatory reaction in the anterior chamber, the space behind the cornea, sometimes with a layer of pus called a hypopyon.
Management sounds urgent for ulcerative keratitis.
Absolutely. It requires immediate ophthalmologic consultation. Empirical treatment with fortified, high concentration, topical antibiotics, sometimes supplemented with subconjunctival injections, is started right away, but only after corneal scrapings have been taken for stains, Gram, Giemsa, KOH, and cultures to identify the specific organism. You always have to consider fungal causes, especially in warm, humid climates or after trauma involving plant matter, and acanthamoeba, particularly with poor contact lens hygiene or exposure to contaminated water.
Herpes simplex virus, a major cause of infectious blindness from keratitis.
Yes, HSV-1 is a very common cause. Primary infection might just cause a follicular conjunctivitis, easily confused with adenovirus, but you should look for any small vesicles on the eyelids or conjunctiva. The real problem is recurrent disease, where the virus reactivates. The classic sign is a dendritic ulcer, a branching tree-like pattern of epithelial ulceration that stains beautifully with fluorescein. It's pathognomonic, though not always present. Bilateral disease is rare. Stromal involvement deeper in the cornea can cause edema, inflammation, and blood vessel growth, vascularization, often with associated inflammation inside the eye, iridocyclitis.
How is HSV keratitis treated?
Psychoplegic drops help with pain. Antiviral therapy is key, either topical antivirals like trifluridine or ganciclovir gel, or oral antivirals like acyclovir or valacyclovir. If there's significant stromal inflammation causing scarring, topical corticosteroids might be used cautiously by an ophthalmologist to reduce the scarring, but they come with risks that can worsen epithelial disease, cause corneal melting or perforation, increase the risk of secondary infection, and raise eye pressure.
Herpes zoster ophthalmicus shingles affecting the eye area.
This is reactivation of the varicella zoster virus, the chickenpox virus, in the first division of the trigeminal nerve, V1. It causes a painful vesicular rash in that dermatome. Ocular involvement is very common, especially if the rash includes the tip of the nose Hutchinson sign, which indicates involvement of the nasociliary branch supplying the eye.
What kind of eye problems can zoster cause?
A wide range. Corneal involvement is common, sometimes with dendrite-like lesions, though they look different from HSV dendrites. Stromal keratitis, anterior uveitis, elevated eye pressure, palsies of the eye muscles, acute retinal necrosis, a severe retinal inflammation, and long-term problems like scarring and debilitating postherpetic neuralgia. Treatment involves systemic antiviral agents and cycloplegics. Steroids are often used for significant inflammation. Vaccination against shingles is recommended for adults over 50 to prevent reactivation.
Can you clarify the difference between episcleritis and scleritis?
Episcleritis is inflammation of the episclera, a thin layer of connective tissue just under the conjunctiva. It causes localized redness, sometimes nodular, and mild discomfort. It often looks like a sector of conjunctivitis, but without discharge. It's frequently idiopathic, but can be linked to autoimmune conditions. Scleritis is much more serious. It's inflammation of the deeper, thicker white wall of the eye, the sclera itself. It is strongly associated with systemic connective tissue diseases like rheumatoid arthritis, lupus, granulomatosis with polyangiitis, etc.
How does scleritis present?
Anterior scleritis often has a characteristic deep, violaceous, violet hue to the redness and causes severe, deep, boring eye pain and tenderness. It can be diffuse or nodular. Posterior scleritis affects the back of the sclera, so redness might be minimal, but it can cause reduced vision, proptosis, choroidal swelling, and restricted eye movements. Treatment for episcleritis might just be observation or topical NSAIDs. Scleritis usually requires systemic NSAIDs, and if that fails, systemic glucocorticoids or other immunosuppressants are needed, especially to manage the underlying autoimmune disease.
Anterior uveitis inflammation inside the front part of the eye.
Right, inflammation of the iris and or the ciliary body, also called uveitis or iridocyclitis. This diagnosis requires a slit lamp exam. You need to see signs of inflammation inside the eye, specifically inflammatory cells floating in the aqueous humor, the fluid in the front chamber, or stuck to the back surface of the cornea. These are called chorotic precipitates, or KPs.
What causes anterior uveitis?
While many cases are idiopathic, no specific cause found, it has well-known associations with systemic inflammatory conditions like ankylosing spondylitis, sarcoidosis, juvenile idiopathic arthritis, inflammatory bowel disease, psoriasis, reactive arthritis, and Behçet's disease. Infections like herpes, syphilis, Lyme disease, TB, or leprosy can also cause it. A workup for systemic causes is usually done if the uveitis is recurrent, bilateral, or unusually severe.
Treatment for anterior uveitis.
The mainstays are topical corticosteroids to reduce the inflammation and prevent scarring, like adhesions between the iris and lens, called posterior synechia. Pupillary dilation, using cycloplegic drops, is also crucial. It relieves pain from ciliary spasm and helps prevent those synechiae from forming.
And posterior uveitis affects the back.
Yes, inflammation involving the vitreous gel, the retina, or the choroid, a vascular layer under the retina. You need a dilated fundus exam to see this. Posterior uveitis is actually more likely to be associated with an identifiable systemic disease or infection compared to anterior uveitis. Pain uveitis means inflammation is present in both the front and back segments.
Causes of posterior uveitis.
Again, a long list. Autoimmune conditions like sarcoidosis, Behçet's, Vogt-Koyanagi-Harada syndrome. Infections are very important causes. Toxoplasmosis is common. Also syphilis, PB, viral retinitis, CMV, herpes, fungal infections, candida, aspergillus, parasites, toxocariasis, cysticercosis, and others like cat scratch disease or Lyme. Pars planitis, or intermediate uveitis, is inflammation predominantly in the peripheral retina and vitreous space, and has a known association with multiple sclerosis. Treatment depends heavily on the cause. Infections need specific antimicrobial therapy, while non-infectious inflammatory causes are treated with glucocorticoids, often systemic, periocular, or intraocular implants, or other immunosuppressants, including biologics like adalimumab for chronic cases.
Acute angle closure glaucoma, a different mechanism for a red, painful eye.
Very different. It's relatively uncommon overall, but a true emergency, and more prevalent in certain populations, like those of Asian descent. It happens in eyes that are anatomically predisposed, specifically eyes with a shallow anterior chamber. This can be because the eye is short, hyperopic, or because the lens inside has become enlarged, often with age or cataract formation.
What triggers the attack?
When the pupil dilates to a mid-position, the peripheral iris can bunch up and block the trabecular meshwork, the drainage angle for the aqueous fluid. This leads to a very sudden, very dramatic rise in intraocular pressure, IOP. Symptoms are severe eye pain, intense redness, a hazy or steamy-looking cornea due to edema, which causes patients to see halos around lights, and blurred vision. Importantly, the high pressure often triggers systemic symptoms like nausea, vomiting, and headache, which can sometimes mislead diagnosis towards a neurological or abdominal problem.
Diagnosis relies on measuring the pressure.
Yes, measuring of the very high IOP during the attack is key, along with examining the anterior chamber angle with a special lens, codioscopy, to confirm it's narrow or closed. Treatment is urgent to lower the pressure. This involves topical eye drops, like beta blockers, alpha agonists, prostaglandin analogs, and systemic medication, like acetazolamide, oral or IV. Pilocarpine drops are used to constrict the pupil, which helps pull the iris away from the angle, but only once the pressure starts to come down. The definitive treatment is usually a laser peripheral iridectomy, which creates a small hole in the peripheral iris to allow fluid to bypass the pupil block.
The source made a point about dilating pupils for routine exams.
Yes, it's an important practical point. While dilating drops can theoretically trigger an angle closure attack in a susceptible eye, the risk is actually very low. This small risk is generally considered far outweighed by the benefit of getting a good view of the optic nerve and retina to rule out other serious conditions. Furthermore, if an attack is triggered by dilation, it effectively identifies a patient who needs a prophylactic laser iridectomy to prevent future spontaneous attacks.
Endophthalmitis infection inside the eyeball.
A devastating condition. It's an infection, bacterial, viral, fungal, or parasitic, of the internal structures of the eye. It can occur from hematogenous seeding, meaning infections spreading through the bloodstream, in patients who are chronically ill, diabetic, immunosuppressed, have indwelling IV catheters, or known bacteremia fungemia.
How does it present?
Usually with severe ocular pain, profound vision loss, marked redness and swelling chemosis, often eyelid edema, and frequently a hypopyon, that layer of pus in the anterior chamber. Sometimes infectious emboli, maybe from infected heart valves or dental abscesses, can travel through the bloodstream and lodge in the retinal circulation. The source mentions Roth spots, those white-centered retinal hemorrhages, which are classically associated with subacute bacterial endocarditis, but can be seen in other conditions too.
Can endophthalmitis happen after surgery or trauma?
Yes, that's actually a more common route. It's a known, though fortunately rare, complication of intraocular surgery, like cataract or glaucoma filtering surgery. It can also result from penetrating eye trauma, especially if there's an occult, hidden, retained intraocular foreign body, or even unrecognized minor trauma. It's absolutely critical to consider endophthalmitis in any case of unexplained severe intraocular inflammation or infection, especially in a relevant clinical setting.
Okay, that covers the red, painful eye spectrum extensively. Now let's shift to transient or sudden visual loss. Amaurosis fugax is a key term here.
Right. Amaurosis fugax literally means fleeting darkness. It's essentially a transient ischemic attack, or TIA, of the retina or optic nerve. The neural tissue in the eye has a very high metabolic rate, so even a few seconds of interrupted blood flow can cause temporary monocular blindness.
How do patients describe it?
Often as a curtain or shade coming down over the vision in one eye, sometimes affecting only part of the visual field. It usually lasts minutes, then vision returns completely.
What causes the temporary blockage?
Most commonly, it's a small embolus, a tiny particle traveling in the bloodstream that gets stuck temporarily in one of the retinal arterioles, as shown in Fig 32-5. If the embolus breaks up quickly or passes downstream, blood flow is restored and vision returns, usually without permanent damage. However, if the blockage lasts longer, it causes infarction, death of the interretinal layers. A complete central retinal artery occlusion results in a characteristic appearance. The retina looks milky white and swollen, except for the fovea, which retains its reddish color because its blood supply comes from the underlying choroid, giving the classic cherry red spot, Figure 32-6.
Where do these emboli typically come from?
The most frequent source is atherosclerotic plaque in the carotid artery in the neck, or sometimes from the aorta. Bits of plaque or clot can break off and travel to the eye. Another major source is the heart, especially in conditions like atrial fibrillation, diseased heart valves, or areas of poor wall motion after a heart attack where clots can form.
What are the emboli made of?
They can be cholesterol crystals, which often look like bright, refractile yellow plaques called Hollenhorst plaques when seen in the retinal vessels. They can also be made of calcium, often from calcified heart valves, or platelet fibrin material clots.
Are there other causes besides emboli?
Less commonly, amaurosis fugax can be caused by critically low blood flow, hypoperfusion, through the central retinal artery, usually due to very severe stenosis, narrowing, of the ipsilateral carotid artery combined with poor collateral circulation. This type might occur when blood pressure drops systemically. The source also mentions rarer associations like retinal migraine, certain autoimmune conditions like lupus or antiphospholipid syndrome, hypercoagulable states, temporal arteritis, IV drug abuse, or certain blood dyscrasias.
Hypertensive retinopathy can high blood pressure cause sudden vision issues too.
Yes. Chronically high blood pressure damages the small blood vessels in the retina, leading to sclerosis, hardening of the arterioles. Signs of hypertensive retinopathy include splinter hemorrhages, cotton wool spots, which are actually tiny infarcts in the nerve fiber layer caused by arteriolar occlusion, and leakage leading to hard exudates, often arranged in a star pattern around the macula. Sudden visual loss can occur during a hypertensive crisis, where extremely high pressure causes acute ischemia of the retina or optic disc due to the vasospasm, or leads to ischemic optic disc swelling, papilledema, and malignant hypertension. Treatment involves lowering the blood pressure, but the source emphasizes doing this carefully, as lowering it too rapidly can actually worsen ischemia to the optic nerve head.
Retinal vein occlusion that's blocking the outflow.
Exactly. An impending branch or central retinal vein occlusion can sometimes cause prolonged visual obscurations, mimicking amaurosis fugax. When a full occlusion occurs, the signs are quite dramatic. The retinal veins become engorged, tortuous, and look inflamed, and there are numerous retinal hemorrhages, often described as a blood and thunder appearance. This leads to retinal edema, ischemia, and often significant, sometimes permanent visual loss.
Risk factors for vein occlusion.
Often it's idiopathic, but hypertension, diabetes, and glaucoma are major risk factors. Conditions that make the blood thicker or more prone to clotting, like polycythemia, thrombocythemia, or hypercoagulable states, should be investigated and treated if found. Aspirin might offer some benefit.
Anterior ischemic optic neuropathy, AION, what's the mechanism here?
This is caused by insufficient blood flow through the short posterior ciliary arteries, which are the main supply to the optic nerve head, the optic disc. It typically causes sudden, painless monocular visual loss, though sometimes it can progress in a stuttering fashion over a few days. On examination, the optic disc looks swollen, edematous, usually pale, and often has splinter hemorrhages on or around it.
And there are two crucial types, non-arteritic and arteritic.
Yes, distinguishing these is critical. Non-arteritic A-ion, NA-ion, is by far the most common form. The exact cause isn't always clear, but risk factors include diabetes, hypertension, high cholesterol, sleep apnea, and potentially certain medications like erectile dysfunction drugs, though the link is debated. A key predisposing factor is having a disc at risk, an optic disc that's anatomically crowded, with a small or absent physiological cup. Unfortunately, there's no proven treatment to reverse the vision loss from AI-ion, and glucocorticoids are generally not considered effective. Having NAION in one eye significantly increases the risk for the other eye over time.
But the arteritic form AAI-on is a true emergency.
Absolutely. This accounts for maybe 5% or so of AI-on cases and is caused by giant cell arteritis, GCA, also known as temporal arteritis. This is an inflammation of medium and large arteries, and it predominantly affects older adults, especially Caucasian females over 60. Recognizing AI-ion immediately is paramount, because prompt treatment with high-dose systemic glucocorticoids can often prevent devastating vision loss in the second eye, which can happen rapidly if untreated.
How do you suspect AI-ion?
Besides the sudden vision loss and swollen disc, patients often have associated symptoms of GCA. New onset headache, often temporal, scalp tenderness, jaw claudication, pain with chewing, constitutional symptoms like fever, malaise, weight loss, and often symptoms of polymyalgia rheumatica, aching and stiffness in the shoulders and hips. Lab tests usually show a markedly elevated erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP.
Confirmation requires a biopsy.
Yes, a temporal artery biopsy is considered the gold standard for diagnosing GCA. However, because vision loss can be rapid and irreversible, treatment with high-dose steroids should be started immediately on suspicion without waiting for the biopsy result. The biopsy should then be performed as soon as possible, ideally within a week or two of starting steroids. It can remain positive for a while. A negative biopsy by an experienced pathologist makes GCA less likely, and steroids might be tapered off. The source also mentions tocilizumab, an IL-6 inhibitor, as an alternative or steroid-sparing agent for GCA.
Posterior ischemic optic neuropathy, PION, is different.
Yes, less common. This involves ischemia to the part of the optic nerve behind the eyeball, within the orbit. It typically occurs in the setting of severe systemic hypoperfusion, often a combination of severe anemia from massive blood loss, like during surgery, trauma, or GI bleed, and significant hypotension, shock. Unlike AION, the optic disc usually looks normal initially because the swelling is further back. Treatment requires immediate correction of the underlying anemia, blood transfusion, and hypotension to try and salvage vision.
Optic neuritis, inflammation of the optic nerve.
A very common cause of acute visual loss, especially in younger adults, typically between 20 and 45, and more common in women. It's an inflammatory demyelinating condition. The optic neuritis treatment trial, ONTT, gave us a lot of information. The average age was 32, 77% were female, and crucially, 92% reported eye pain, typically worse with eye movement.
Does the optic disc always look swollen?
No. About one-third of cases in the ONTT had disc swelling, papillitis. But in two-thirds, the inflammation was further back behind the eye, retrobulbar optic neuritis, so the optic disc looked completely normal initially. This is the classic patient sees nothing, doctor sees nothing scenario. Optic disc pallor, indicating nerve damage, usually develops later over weeks to months.
What's the prognosis like?
Generally quite good for vision recovery. The ONTT found that vision typically improves gradually over weeks to months, even without treatment, often returning to near normal levels after a single episode. If vision doesn't recover well, the diagnosis might need to be reconsidered. Treatment with high-dose intravenous steroids followed by oral prednisone was found to speed up the rate of visual recovery, although it didn't change the final visual outcome at 6 months compared to placebo or oral prednisone alone. In fact, oral prednisone alone was associated with a slightly higher risk of recurrence. 4E steroids are often recommended, especially if vision loss is severe, for example, worse than 2100.
And the link to multiple sclerosis, MS, is significant.
Very significant. The ONTT found that the 15-year risk of developing clinically definite MS after an episode of optic neuritis was about 50% overall. The risk was much higher, around 72%, if the initial brain MRI scan showed white matter lesions characteristic of MS, and lower, around 25%, if the MRI was normal. So a brain MRI is generally recommended after a first episode of optic neuritis to help stratify this risk and guide decisions about starting MS disease-modifying therapies. The source also distinguishes neuromyelitis optica, NMO.
Right, that's a different autoimmune condition.
Yes, NMO, or NMO spectrum disorder, tends to cause more severe optic neuritis, often affecting longer segments of the optic nerve, frequently bilateral, and is associated with transverse myelitis, spinal cord inflammation. Specific antibodies like anti-aquaporin 4, AQP4, or anti-MOG Myelin oligodendrocyte glycoprotein help diagnose it. Treatment involves high-dose steroids for acute attacks and specific immunosuppressive therapies like satralizumab, eculizumab, and inebilizumab to prevent relapses, which can be devastating.
Leber's hereditary optic neuropathy, LHON.
This is a mitochondrial genetic disorder, typically affecting young men. It presents with progressive, painless, usually severe central vision loss, affecting acuity and color in one eye, followed weeks, months, or even years later by similar loss in the other eye. Acutely, the optic disc might look slightly swollen or hyperemic with prominent capillaries, telangiectasias, but without true leakage on angiography. Eventually, profound optic atrophy develops, similar to Fig 3211.
And it's inherited differently.
Yes, it's caused by mutations in mitochondrial DNA, most commonly a specific point mutation, 111778, in the gene for NADH subunit 4. Since mitochondria are inherited almost exclusively from the mother, LHON is maternally inherited. However, for reasons not fully understood, it predominantly affects males. Only about 10% of cases are female. Unfortunately, effective treatments, including gene therapy trials, have been disappointing so far.
Toxic and nutritional optic neuropathies.
Certain substances or deficiencies can damage the optic nerve. Acute severe vision loss with bilateral disc swelling and central or secocentral scotomas can occur with exposure to toxins like methanol, wood alcohol, ethylene glycol antifreeze, ethambutol, an anti-TB drug, or carbon monoxide. More commonly, exposure to various drugs or chronic nutritional deficiencies leads to a gradual, progressive, painless bilateral central visual loss with eventual optic atrophy.
What kind of agents?
The source lists many possibilities, though the strength of evidence varies. Disulfiram, chloramphenicol, amiodarone, certain antibiotics, lead, arsenic, thallium, isoniazid. Also, deficiency states, particularly involving B vitamins, thiamine B1, B12, and folate, often seen in alcoholism, malabsorption syndromes, starvation, or after gastric bypass surgery, can cause insidious optic neuropathy. Checking these vitamin levels is important in any case of unexplained bilateral central scotomas or optic pallor.
Papilledema. This is specifically disc swelling due to high intracranial pressure.
Correct. Papilledema specifically refers to bilateral optic disc swelling caused by raised intracranial pressure, ICP, as shown nicely in Fig 3212. It's important to distinguish it from other causes of optic disc edema, like AION or optic neuritis, although visually they can sometimes look similar initially. Headache is a common symptom of raised ICP, but not always present with papilledema.
What visual symptoms does papilledema cause?
The classic symptom is transient visual obscurations, TVOs, brief episodes lasting seconds, where vision dims or blacks out in one or both eyes, often triggered by changes in posture like bending over or standing up quickly. More prolonged or frequent obscurations are a more ominous sign. Visual acuity usually remains normal until papilledema is very severe or long-standing, or unless there's associated macular edema or hemorrhage.
How does it affect visual fields?
Characteristically, papilledema causes enlargement of the physiological blind spots. If it persists untreated, it leads to progressive constriction of the peripheral visual fields, which can be insidious. Eventually, this leads to irreversible optic atrophy and central vision loss. A concerning sign is when the disc swelling starts to decrease in someone with chronic papilledema and poor vision. It often means the nerve is dying, not that the pressure problem is resolved.
How do you evaluate suspected papilledema?
The first step is urgent neuroimaging, MRI or CT, to rule out an intracranial mass, hemorrhage, hydrocephalus, or other structural cause of the raised ICP. Porphyrinography should also be done to check for dural venous sinus thrombosis. If imaging is negative, a lumbar puncture is needed to measure the opening pressure with a patient lying on their side. Elevated pressure with normal CSF composition points towards idiopathic intracranial hypertension, IIH, also known previously as pseudotumor cerebri.
IIH has a typical patient profile.
Yes, it predominantly affects overweight women of childbearing age. Treatment aims to lower the ICP to protect vision. Acetazolamide, a carbonic anhydrase inhibitor, is the main medical therapy. It reduces CSF production. Weight loss is absolutely crucial and can lead to remission. For patients with severe vision loss or progression despite medical therapy, surgical procedures like optic nerve sheath fenestration or CSF shunting, lumboperitoneal or ventriculoperitoneal, may be necessary. Stenting of narrow dural venous sinuses is also being explored as a treatment.
Lastly, under sudden transient loss or disc swelling, optic disc drusen.
These are different from the drusen in macular degeneration. Optic disc drusen are collections of hyaline-like calcified material deposited within the optic nerve head itself. They're often inherited and more common in people of Northern European descent. If they're visible on the surface, they look like glistening refractile bodies. The diagnostic challenge comes when they're buried deeper within the nerve substance.
Because they can make the disc look swollen.
Exactly. Buried drusen can elevate the optic disc margins and obscure the cup, mimicking true papilledema. This is called pseudo-papilledema. Recognizing this is vital to avoid unnecessary and invasive investigations for raised ICP. The best way to detect buried drusen is usually with B-scan ultrasound of the eye, where they show up as highly reflective spots due to the calcium. They can also sometimes be seen on CT scans or with OCT imaging.
Are they harmless?
Mostly, yes. They're usually an incidental finding. However, they can sometimes cause transient visual obscurations, similar to papilledema. Over time, they can also cause slow, progressive damage to the optic nerve fibers, leading to visual field defects like enlarged blind spots or arcuate scotomas. As the nerve fibers atrophy, the drusen may become more visible on the surface. They also slightly increase the risk of complications like hemorrhages around the disc, choroidal neovascular membranes, or even AION. There's no treatment for the drusen themselves.
Okay, let's transition to conditions causing more chronic, gradual visual loss. Vitreous degeneration is a common one with age.
Yes. The vitreous gel that fills the main cavity of the eye tends to liquefy and shrink as we get older. This creates opacities within the gel. Patients perceive these as floater spots, lines, or cobweb shapes that drift around in their vision. These are just the shadows cast by the opacities onto the retina.
And flashes of light, too.
Right, photoxia. These are usually brief, arc-like flashes seen in the peripheral vision of one eye. They're caused by the vitreous gel pulling or tugging on the retina as it degenerates and moves. It's important to distinguish these from the scintillating, often geometric, shimmering lights seen bilaterally in a classic migraine aura, which lasts much longer, typically 15-30 minutes.
Can this lead to a posterior vitreous detachment, TVD?
Yes. Often this aging process culminates in a PVD, where the vitreous gel suddenly separates from the surface of the retina. This is a very common event, especially in people over 50 or 60. It's often heralded by a sudden onset or increase in floaters, sometimes described as a shower of floaters, and flashes of light. While a PVD itself is usually harmless, the key concern is whether the separating vitreous has torn the retina in the process.
So anyone with new flashes and floaters needs an urgent eye exam.
Absolutely. A careful, dilated fundus examination is crucial to look for any retinal tears or holes, especially in the periphery. If a tear or hole is found, it needs to be treated promptly, usually with laser photocoagulation or cryotherapy, freezing around the break, to seal it and prevent fluid from getting underneath and causing a retinal detachment.
What if a blood vessel gets torn during the PVD?
That causes a vitreous hemorrhage bleeding into the vitreous cavity. This causes sudden, often dramatic loss of vision, frequently described as a dark haze, veil, or cloud filling the vision. On examination, the view of the retina is obscured by the blood. Ultrasound is needed in this case to assess the status of the retina underneath, to check for tears or detachment. Vitreous hemorrhage may clear on its own over weeks or months, but if it doesn't, or if there's an underlying retinal detachment, vitrectomy surgery, removal of the vitreous gel and blood, is required. Vitreous hemorrhage can also occur from fragile new blood vessels, particularly in conditions like diabetic retinopathy or retinal vein occlusion.
Retinal detachment itself a serious emergency.
Definitely. Symptoms often start with the flashes and floaters of a PVD or tear, but then progress to a visual field defect, a shadow or curtain starting in the periphery and expanding towards the center. If the detachment spreads to involve the macula, central visual acuity drops significantly, and there might be an afferent pupillary defect.
What causes the detachment usually?
The most common type is rhegmatogenous, which means it's caused by a break, a hole or tear in the retina. This allows the liquefied vitreous gel to seep through the break into the potential space between the neurosensory retina and the underlying retinal pigment epithelium, RPE, peeling the retina off. People at higher risk include those with high myopia, a history of eye trauma, previous cataract surgery, or specific peripheral retinal degenerations like lattice degeneration. Diagnosis is confirmed by dilated ophthalmoscopy, and treatment is surgical, aiming to close the breaks and reattach the retina. Prompt surgery offers the best chance of preserving vision, especially if the macula is still attached.
Chronic glaucoma. We touched on the field defects, but let's discuss it as a cause of chronic loss.
It's a huge cause of irreversible blindness worldwide, second only to cataracts overall. It's a slowly progressive optic neuropathy damage to the optic nerve usually, but not always, associated with chronically elevated intraocular pressure, IOP. It's particularly prevalent in people of African descent. The exact way that elevated IOP damages the optic nerve fibers isn't fully understood, but it leads to characteristic changes.
The cupping of the optic disc.
Exactly. As nerve fibers are lost, particularly those entering the inferior and superior poles of the disc, the neural rim tissue shrinks and the central physiological cup gets larger and deeper. Figure 3215. We measure this as the cup-to-disc ratio. While a large cup can be suspicious, the normal range varies greatly. The key is progressive cupping documented over time on serial examinations, along with corresponding visual field loss, those typical arcuate defects or nasal steps, and thinning of the nerve fiber layer seen on OCT scans.
Most patients have open-angle glaucoma.
Yes. In open-angle glaucoma, the drainage angle itself looks normal on gonioscopy, but there's increased resistance to aqueous outflow through the trabecular meshwork, leading to elevated IOP. The cause is often unknown, though genetic factors play a role in some heritable forms. However, about a third of patients have normal tension glaucoma, where characteristic optic nerve damage and field loss occur despite IOP consistently measuring within the normal range, below 21 millivaries G. High myopia seems to be a risk factor for this type.
Is chronic glaucoma symptomatic?
This is the crucial point. Chronic open-angle glaucoma and even chronic angle closure glaucoma are typically asymptomatic until very advanced stages. There's no pain, unlike acute angle closure. Central vision often remains good until the very end. This means patients can lose a significant amount of peripheral vision without realizing it. That's why screening is so important, checking IOP and carefully examining the optic disc for cupping, especially in higher-risk individuals.
How is it treated?
The goal is always to lower the IOP to slow down or halt further nerve damage. First-line treatment is usually topical eye drops. There are several classes: prostaglandin analogs, beta blockers, alpha-adrenergic agonists, carbonic anhydrase inhibitors, and cholinergic agonists. They work either by reducing aqueous production or increasing outflow. It's important to be aware of potential systemic side effects from eye drops, especially beta blockers, which can cause slowed heart rate, low blood pressure, worsen asthma, or cause fatigue or depression. If drops aren't sufficient or tolerated, laser trabeculoplasty can be performed to improve outflow through the trabecular meshwork. If medical and laser therapy fail, surgical procedures like trabeculectomy, creating a new drainage channel, or implanting a glaucoma drainage device shunt are options.
Age-related macular degeneration, AMD, another major cause of chronic central loss.
Yes, the leading cause of severe, irreversible central vision loss in the elderly and developed nations. It affects the macula, that central part of the retina responsible for sharp, detailed vision. There are two main forms: the more common non-exudative or dry AMD, and the less common but often more rapidly damaging exudative or wet AMD. Inflammation and genetic factors, particularly involving the complement system, like complement factor H variants, seem to play significant roles.
Describe the dry form first.
Dry AMD starts with the appearance of drusen, these yellowish extracellular deposits that accumulate beneath the retinal pigment epithelium, RPE, in the macula. Initially, they might be small and sparse, but over time they can become larger, more numerous, and merge together, confluent. Eventually, the RPE itself can detach, atrophy, waste away, or develop geographic atrophy, patches of complete RPE and photoreceptor loss, leading to gradual blurring and loss of central vision because the overlying photoreceptors are damaged or lost.
Is there treatment for dry AMD?
The age-related eye disease study, ARIDS and ARIDS 2, showed that taking a specific formulation of high-dose antioxidant vitamins C and E, lutein, zeaxanthin, zinc, and copper can significantly slow the progression from intermediate stages of dry AMD to advanced AMD, either geographic atrophy or wet AMD. It doesn't prevent it entirely or restore lost vision, but it slows the decline.
And the wet form?
Wet AMD develops in about 10-15% of people with AMD. It's characterized by choroidal neovascularization, CNV, the growth of abnormal new blood vessels from the choroid layer up through defects in Bruch's membrane into the space under the RPE or even under the retina itself. These new vessels are fragile and leaky. They leak fluid, causing the retina to swell and detach locally, which leads to distorted vision, metamorphopsia, straight lines looking wavy, and blurring. They can also bleed suddenly, causing acute loss of central vision.
How is wet AMD detected and treated?
These neovascular membranes can be hard to see directly on ophthalmoscopy. Diagnosis relies heavily on imaging, fluorescein angiography, which shows leakage from the abnormal vessels, and especially optical coherence tomography, OCT, which provides detailed cross-sectional images showing fluid under or within the retina and the CNV membrane itself. The treatment for wet AMD has been revolutionized by anti-VEGF therapy.
Those injections into the eye.
Yes, intraocular injections of drugs that block vascular endothelial growth factor, VEGF agents like bevacizumab, ranibizumab, aflibercept, and brolucizumab. VEGF is a key signal driving the growth and leakage of these abnormal vessels. Injecting these drugs directly into the vitreous cavity, often repeatedly, initially monthly, causes the CNV membranes to regress, reduces leakage, and can significantly improve or at least stabilize vision in many patients, preventing the severe scarring, disciform scar that used to be the typical outcome.
Central serous chorioretinopathy, CSCR.
This condition typically affects younger adults, predominantly males between 20 and 50. It's characterized by leakage of serous fluid from the choroid through a dysfunctional RPE, causing a localized blister-like detachment of the neurosensory retina, usually in the macula. This causes blurred vision and metamorphopsia, often with micropsia, objects looking smaller. The detached area looks like a shallow, clear elevation on exam. OCT clearly shows the subretinal fluid, and fluorescein angiography pinpoints the leakage site. The exact cause is unknown, but it's associated with stress and corticosteroid use. Does it resolve? Often the fluid resorbs spontaneously over weeks to months and vision recovers, although some subtle distortion or color desaturation might persist. However, recurrences are common, and chronic CSCR can lead to more permanent RPE changes and vision loss. Laser photocoagulation applied directly to the leakage point can speed up resolution in some cases, especially if leakage is outside the very center.
Diabetic retinopathy, we mentioned the risk. How does it cause chronic loss?
It's a major cause of blindness, especially in working-age adults in the U.S. It's a microvascular complication of diabetes that develops over years. Nearly all patients with long-standing diabetes eventually develop some signs. That's why regular dilated eye exams are absolutely essential for everyone with diabetes. The advanced or proliferative stage involves the growth of fragile new blood vessels, neovascularization, on the retina or optic disc, figure 3217.
And these new vessels cause problems.
Big problems. They can bleed into the vitreous, causing sudden vision loss. They can contract and pull on the retina, causing tractional retinal detachment. They can also grow into the angle of the eye, causing neovascular glaucoma, which is very difficult to treat. The mainstay of preventing these sight-threatening complications has been panretinal photocoagulation, PRP, applying laser burns throughout the peripheral retina to reduce the ischemic drive for neovascularization. More recently, anti-VEGF injections have also proven highly effective for treating both proliferative diabetic retinopathy and diabetic macular edema, swelling in the macula, another major cause of vision loss in diabetes, often requiring repeated injections.
Retinitis pigmentosa, RP, that's inherited.
Yes, RP is a group of inherited retinal degenerations, primarily affecting the photoreceptors, rods first, then cones. It leads to progressive night blindness, gradual constriction of the peripheral visual field, often starting as a mid-peripheral ring scotoma, and eventual loss of central acuity. The electroretinogram, ERG, which measures retinal electrical responses to light, is characteristically abnormal. Inheritance patterns vary autosomal dominant, recessive, X-linked, or sporadic.
What's the classic sign on exam?
The presence of irregular black pigment deposits in the mid-peripheral retina, often described as bone spicules. The optic disc often looks waxy pale, and the retinal arterioles become attenuated, narrowed. Despite the name, it's a degenerative condition, not primarily inflammatory. Mutations in numerous genes involved in photoreceptor function, like rhodopsin or structure, have been identified.
Any treatment?
High-dose vitamin A palmitate, 15,000 IU day, was shown in one trial to slightly slow the rate of ERG decline, but didn't significantly impact visual acuity or field loss. Gene therapy has shown some promise for one rare form, Leber's congenital amaurosis due to RPE65 mutations, restoring some visual function. Certain rare systemic hereditary diseases can be associated with RP-like retinal changes. And importantly, some chronic medications, notably chloroquine, hydroxychloroquine, and high doses of thiordazine, can cause a toxic retinopathy that mimics RP. Patients on hydroxychloroquine need regular screening for early signs of macular toxicity, bullseye maculopathy.
A proretinal membrane, ERM.
This is a thin sheet of scar-like fibrocellular tissue that grows across the inner surface of the retina, usually over the macula. It can contract and wrinkle the underlying retina, causing metamorphopsia, distortion, and blurred vision. On examination, it looks like a glistening cellophane-like film on the retinal surface, sometimes called macular pucker. It's quite common, especially in people over 50, and usually affects just one eye.
What causes it?
Most are idiopathic, spontaneous. But ERMs can also develop secondary to other retinal conditions like diabetic retinopathy, vein occlusions, retinal detachment repair, trauma, or inflammation. If the membrane causes significant visual distortion or reduces acuity, say below 624 or 2080, surgical treatment by vitrectomy with peeling of the membrane can often improve vision and reduce distortion. ERM contraction can sometimes also cause a full-thickness macular hole, although most macular holes are thought to be caused by focal vitreous traction directly on the fovea. Vitrectomy surgery can also be effective in closing macular holes and improving vision in selected cases.
Ocular tumors. Melanoma is the most common primary one.
Yes, primary melanoma arising within the eye, uveal melanoma, occurs in about 2,000 people per year in the U.S., figure 3219. Most, about 85%, arise in the choroid, but they can also start in the iris or ciliary body. They typically present as painless, progressive visual loss or a visual field defect if they affect the macula or grow large. Differentiating a small melanoma from a benign choroidal nevus, mole, can be very difficult initially and often requires careful monitoring with serial examinations and imaging, like ultrasound or OCT, to document growth. Risk factors include fair skin and light eye color. Specific genetic mutations, GNAQ, GNA11, are common.
What's the prognosis?
Unfortunately, about half of uveal melanomas eventually metastasize, most commonly to the liver. Treatment depends on the size and location. Smaller tumors are often treated with radiation therapy like plaque brachytherapy, while larger tumors may require enucleation or removal of the eye.
And metastatic tumors to the eye
are actually more common than primary intraocular melanomas. The choroid is a frequent site for metastases, especially from breast and lung cancer. Leukemia and lymphoma can also infiltrate ocular tissues. Sometimes the only sign might be inflammatory cells in the vitreous, mimicking chronic uveitis. So in any patient with unexplained vision loss, especially with a history of cancer, metastatic disease must be considered. CT or MRI scanning is often needed after the basic eye exam.
The source also mentions specific tumors affecting the optic nerve or chiasm.
Right. Optic nerve sheath meningioma wraps around the optic nerve, often causing slow progressive visual loss, optic atrophy, and sometimes opticiliary shunt vessels on the disc, dilated vessels that bypass the blocked central retinal vein. Optic nerve glioma is a tumor of the nerve itself. In children, it's usually a low-grade astrocytoma with a relatively good prognosis, especially as associated with neurofibromatosis type 1. In adults, primary optic nerve gliomas are rare and usually malignant. Tumors pressing on the chiasm, pituitary adenoma, meningioma, craniopharyngioma, cause that characteristic bitemporal field loss, often presenting subtly initially. Pituitary apoplexy is a rare emergency of sudden hemorrhage or infarction within a pituitary adenoma, causing acute vision loss, headache, and often cranial nerve palsies.
Let's address proptosis or exophthalmos, the bulging eye.
First step is always to decide if one eye is truly bulging, proptosis, or if the other eye is actually sunken in ophthalmos. True ophthalmos can happen after orbital floor fractures, blowout fracture, with atrophy of orbital fat, or a congenitally small eye. Apparent ophthalmos can occur with Horner syndrome due to the droopy eyelid. Proptosis implies something is pushing the eye forward from within the orbit, a mass, inflammation, swollen muscles, vascular congestion. It always warrants imaging, usually CT or MRI of the orbits. Proptosis can be measured with a Hertel exophthalmometer or judged by looking down from above the patient's forehead. Fig 3220.
What's the most common cause of proptosis in adults?
Graves' ophthalmopathy, related to thyroid disease. It's an autoimmune process causing inflammation and swelling of the orbital tissues, particularly the extraocular muscles, especially the inferior and medial recti and orbital fat. It's often asymmetric and can appear unilateral initially.
Key signs and symptoms of Graves' eye disease.
Besides the proptosis itself, common signs include upper eyelid retraction, giving a staring appearance, lid lag on down gaze, conjunctival injection and swelling, chemosis, restricted eye movements leading to diplopia, often vertical diplopia due to inferior rectus involvement, and corneal exposure due to inability to close the eyes properly. In severe cases, the swollen muscles can compress the optic nerve at the orbital apex, causing vision loss, a true emergency.
Diagnosis and management.
Diagnosis is often clinical, supported by thyroid function tests and thyroid antibody levels, like TSI. Orbital imaging shows characteristic enlargement of the muscle bellies, typically sparing the tendons. Management involves controlling the underlying thyroid disease, managing symptoms like dry eye with lubricants, and taping lids at night, and addressing the orbital inflammation. Oral prednisone can help temporarily, but often rebounds. Teprotumumab, an IGF-1 receptor inhibitor, is a newer targeted therapy shown to reduce proptosis and diplopia. Radiation therapy is generally not effective. Surgery, like orbital decompression, removing bone to make more space, may be needed for severe proptosis or optic nerve compression. Eye muscle surgery or prisms can address persistent diplopia later.
Orbital pseudotumor sounds similar, but isn't thyroid-related.
Right. It's an idiopathic inflammatory condition of the orbit. A key distinguishing feature from Graves is often prominent pain. It can cause proptosis, diplopia, chypaesthesis, and orbital congestion. It's a diagnosis of exclusion after ruling out specific causes like infection, vasculitis, example GPA, or sarcoidosis. Imaging often shows swollen eye muscles, but unlike Graves, the muscle tendons are frequently involved as well. If it extends back to involve the superior orbital fissure or cavernous sinus, it's called Tolosa-Hunt syndrome. Biopsy usually shows nonspecific inflammation. A dramatic response to systemic corticosteroids is often used to support the diagnosis.
Orbital cellulitis, that's infection.
Yes, a serious bacterial infection of the tissues within the orbit, behind the orbital septum. It presents acutely with pain, eyelid redness and swelling, proptosis, chemosis, restricted and painful eye movements, often decreased vision, sometimes an afferent pupil defect, fever, and elevated white blood cell count. It most commonly arises from spread of infection from the adjacent paranasal sinuses, especially the ethmoid sinus, through the thin lamina piperaceae bone. A history of recent URI or sinusitis is common.
Management needs to be aggressive.
Extremely aggressive. This is an emergency due to the risk of vision loss from optic nerve compression or ischemia, spread of infection to the cavernous sinus, causing thrombosis, or meningitis. Immediate hospitalization, IV broad-spectrum antibiotics, covering MRSA, and urgent orbital imaging, CT or MRI, are required. If an abscess is found or vision deteriorates despite antibiotics, prompt surgical drainage of the orbit and or sinuses is necessary.
Orbital tumors can also cause proptosis.
Yes, usually a more slowly progressive, painless proptosis suggests an orbital tumor. Common primary benign tumors include cavernous meningioma, lymphangioma, neurofibroma, schwannoma, dermoid cyst. Malignant primary tumors include lacrimal gland carcinomas or sarcomas, but metastatic tumors are also very common in the orbit, especially from breast, lung, prostate cancer, or lymphoma. Diagnosis usually requires imaging and often biopsy.
Carotid cavernous fistulas, CCFs.
These are abnormal connections between the carotid artery or its branches and the cavernous sinus, the venous structure behind the eye. Direct CCFs are usually high flow, often caused by head trauma, and present dramatically with a pulsating proptosis, loud bruit, whooshing sound heard over the eye or head, marked redness and chemosis, ophthalmoplegia, and high eye pressure. Indirect CCFs, dural shunts, are usually low flow, often spontaneous in older women, and present much more subtly. They might just cause mild redness, slight propsia, maybe some diplopia, and dilated conjunctival vessels. This subtle presentation can be easily mistaken for chronic conjunctivitis or even thyroid eye disease. Listening for bruit or asking if the patient hears one is key. Imaging often shows a dilated superior ophthalmic vein. Treatment for symptomatic CCFs is usually endovascular embolization.
Let's move finally to ptosis, the drooping eyelid.
Ptosis, or blepharoptosis, is an abnormally low upper eyelid position. It can be unilateral or bilateral. Congenital aposis is present from birth, usually due to poor development of the levator palpearia superioris muscle, the main lid elevator. Acquired pallosis develops later. It's important to ask about onset, duration, variability, worse when tired, associated symptoms like diplopia or systemic weakness, history of trauma or surgery, contact lens wear, and family history. Old photos can be very helpful.
What are the main types of acquired ptosis?
The source divides them based on cause. Mechanical ptosis is from physical weight or restriction like excess skin and fat in older people, dermatocalysis, or eyelid swelling scarring from infection, inflammation, tumor, or trauma. Aponeuroticosis is the most common acquired type, especially in older adults. It's due to stretching, thinning, or detachment, the dehiscence, of the levator aponeurosis, the tendon connecting the levator muscle to the eyelid structure, tarsal plate. It can also happen after chronic swelling, eye surgery, like cataract surgery, or long-term hard contact lens wear.
Myogenic ptosis involves the muscle itself?
Yes. This includes myasthenia gravis, where the neuromuscular junction fatigues. Fluctuating ptosis, worse later in the day, is classic for MG. Other causes are rare myopathies affecting the eye muscles. Chronic progressive external ophthalmoplegia, CPEO, is a group of mitochondrial disorders causing slowly progressive symmetric ptosis and limitation of all eye movements. Curran-Sayre syndrome is a variant with associated retinal pigment changes and heart block. Oculopharyngeal dystrophy is an inherited condition starting in middle age with pedicosis, eye movement problems, and difficulty swallowing. Myotonic dystrophy is another inherited condition with ptosis, ophthalmoparesis, cataracts, plus characteristic muscle wasting, myotonia, balding, and cardiac issues.
And neurogenic ptosis.
This is due to a problem with the nerve supply. Either the sympathetic nerve supplying Miller's muscle, which gives a small amount of lift, or the oculomotor nerve, CN3, supplying the main levator muscle. A key differentiator is the pupil. Horner syndrome, sympathetic damage, causes mild ptosis plus a small pupil, miosis, with normal eye movements. A CN3 palsy causes plecosis, often more severe, plus a normal or dilated pupil and limited eye movements, adduction, elevation, depression. A lesion of the oculomotor nucleus in the midbrain is rare but causes bilateral ptosis plus contralateral superior rectus weakness.
Diplopia double vision. What's the first step?
Crucially, determine if it's monocular or binocular. Ask the patient, does the double vision go away if you cover either eye?
What causes monocular diplopia?
If the doubling persists when one eye is covered, the problem is usually within that eye itself. Common causes are optical aberrations, uncorrected refractive error, especially stigmatism, corneal irregularities like keratoconus or scars, cataracts, or sometimes problems at the macula causing distortion. It's generally not neurologically threatening, though it can occasionally be psychogenic or malingering.
And binocular diplopia?
This goes away completely when either eye is covered. It means the two eyes are misaligned, sending slightly different images to the brain that it can't fuse into one. This always requires investigation. Key history points include onset, sudden or gradual. Duration, is it constant or intermittent? Does it vary through the day? Is it worse in certain directions of gaze? And are there any associated neurological or systemic symptoms?
How do you assess it?
Careful testing of eye movements, versions, inductions should reveal a limitation that corresponds to the patient's symptoms, although subtle weaknesses can be hard to spot. The cover test is much more sensitive for detecting the underlying misalignment causing the diplopia. You perform it in different gaze positions and with head tilts to try and identify the pattern of the deviation.
What if someone has a misalignment but no diplopia?
This often happens with long-standing strabismus that started in childhood. If the eyes become misaligned early in life, the brain learns to suppress the image from the non-fixating eye to avoid double vision. This suppression, however, can lead to amblyopia, lazy eye, if not treated. If an adult has an obvious misalignment but denies diplopia, it's usually because it's an old, decompensated childhood strabismus, not a new neurological problem.
What are the broad categories of causes for new onset binocular diplopia?
It's a wide range. Neurological problems affecting the cranial nerves or their central pathways, neuromuscular junction disorders like myasthenia gravis, direct problems with the eye muscles themselves, myopathies, or mechanical restriction of eye movement due to orbital disease, inflammation, tumor, trauma, thyroid eye disease.
How do you differentiate neurogenic from restrictive causes?
Orbital disease usually has other signs like proptosis, pain, redness, or visible swelling. High-resolution orbital imaging, CT or MRI, is very helpful. Myasthenia gravis is a great mimic and should always be considered, especially if the diplopia is variable, fatigable, and doesn't fit a single nerve palsy pattern. Pupils are always normal in MG. Diagnosis also involves observing fatigability, blood tests for antibodies, acetylcholine receptor or MuSK, or, historically, the edrophonium tensilon test.
If you rule out restrictive causes in an MG, you're left with cranial nerve palsies.
Essentially, yes. Isolated palsies of CN3, 3, 4, 6.
Let's quickly recap the key features of each palsy. CN4, oculomotor.
Innervates most eye muscles, medial, inferior, superior recti, inferior oblique, the eyelid lifter, levator, and the pupil constrictor, sphincter. A complete palsy causes the eye to be down and out due to unopposed action of CN size and 4, a droopy eyelid, astosis, and a dilated pupil. Pupil involvement, especially with pain, is concerning for a compressive lesion like an aneurysm and needs urgent investigation. Pupil sparing in an otherwise complete CN3 palsy, especially in an older patient with vascular risk factors, is often due to microvascular ischemia, like from diabetes, and tends to recover spontaneously over months. Aberrant regeneration, miswiring during recovery, causing weird linked movements like the lid lifting on down gaze, occurs after trauma or compression, but not after microvascular palsies, which is a key diagnostic point.
CNIV.
Innervates only the superior oblique muscle, contralateral. Palsy causes vertical diplopia, worse looking down and in, like reading. The affected eye is slightly higher, hypertropia. The head tilt test is characteristic. Diplopia worsens tilting towards the palsied side, improves tilting away, often caused by head trauma or presumed microvascular ischemia, usually improves spontaneously. Prisms or surgery can help if persistent.
CNVI.
Abducens. Innervates only the lateral rectus muscle, abduction, moving eye outward. Palsy causes horizontal diplopia, worse looking toward the side of the palsy. has a long intracranial course, making it vulnerable to various pathologies. Raised ICP, meningitis, skull-based tumors, cavernous sinus problems, trauma, or microvascular ischemia. Again, microvascular palsies often recover spontaneously. Failure to improve warrants further investigation. A lesion of the CNVI's nucleus in the pons causes a gaze palsy, not just abduction weakness.
What if multiple eye movement nerves are affected?
This suggests a process affecting structures where these nerves run close together. Typically, the cavernous sinus, superior orbital fissure, or orbital apex. Causes include tumor, inflammation like Tolosa Hunt or sarcoidosis, infection, especially fungal and diabetics immunocompromised, carotid cavernous fistula, or carcinomatous meningitis. Or it could be a systemic process like GCA, Fisher syndrome, or even a supranuclear gaze palsy mimicking multiple nerve issues.
You mentioned supranuclear disorders. Can you clarify internuclear ophthalmoplegia, INO?
INO is a specific gaze abnormality caused by damage to the medial longitudinal fasciculus, MLF, in the brainstem. The MLF connects the CNVI nucleus on one side to the C in the third nucleus, specifically the medial rectus part on the other side, coordinating horizontal gaze. If the MLF is damaged, say on the left side, the signal from the right CNVI nucleus to the left medial rectus is blocked. So when the person tries to look right, the right eye abducts, moves out normally, but the left eye fails to adduct, move in. There's often a nystagmus in the abducting eye. MS is a very common cause, especially bilateral INO in young adults. Stroke is common in older adults.
And Perinar syndrome again.
That's a dorsal midbrain syndrome affecting vertical gaze control. Classic features are impaired upgaze, convergence retraction nystagmus on attempted upgaze, lid retraction, and Leitner dissociated pupils. Often caused by hydrocephalus or pineal region tumors.
Nystagmus, the rhythmic eye oscillations.
Can be congenital, present from infancy, often associated with poor vision, or acquired. Acquired jerk nystagmus, slow drift, fast correction, is named by the direction of the fast beat, downbeat, upbeat, torsional, horizontal. Gaze-evoked nystagmus appears only when looking off-center, is common, can be caused by drugs, muscle weakness, or cerebellar brainstem lesions. Vestibular nystagmus is associated with vertigo and problems in the inner ear or vestibular pathways. Downbeat nystagmus often points to problems at the craniocervical junction. Upbeat suggests pontine lesions.
Okay, we've covered an immense amount from Chapter 32. Let's briefly touch on the intro to Chapter 33 on smell and taste as the source connects them.
Right. It frames smell, olfaction, and taste, gustation, as chemical senses crucial for monitoring our environment, determining flavor, palatability, warning of dangers like smoke, gas, or spoiled food. Dysfunction clearly impacts quality of life.
And the link to neurodegenerative disease.
Yeah, that's a really significant point mentioned. Reduced sense of smell is now known to be one of the earliest signs of both Parkinson's and Alzheimer's disease, often appearing years before other symptoms manifest. It's considered part of the presymptomatic phase.
The olfactory anatomy overview is interesting, too.
It highlights the unique setup. Odor molecules dissolve in mucus and bind to receptors on olfactory receptor cells in the nasal epithelium. There's a huge diversity of receptors, nearly 400 types, with each cell expressing only one type. These cells are neurons that can actually be replaced by stem cells, which is unusual.
Where did the signals go first?
Their axons pass through the cribriform plate bone to the olfactory bulbs. There, axons from cells with the same receptor type converge onto specific structures called glomeruli. Mitral and tufted cells are the main output neurons from the bulb, modulated by interneurons like granule cells. Interestingly, some of these interneurons are also replaced throughout life via neurogenesis. The output from the bulb goes directly to primary olfactory cortex areas, like the piriform cortex, bypassing the thalamic relay that most other senses use.
That glimpse into another sensory system really underscores the complexity we've seen with vision.
It does. Both are incredibly sophisticated systems for interpreting our world, deeply integrated with brain function and overall health.
So bringing this very deep dive to a close, we've really journeyed through the visual system based on this source material. From the fundamental structure and function, through that detailed clinical assessment toolkit, into the huge array of disorders.
Right, covering everything from the cornea to the cortex, and even touching on those related chemical senses. We've seen how intricate it all is, and how signs in the eye can point to problems elsewhere in the body or brain.
The goal was to gain that thorough, applicable understanding, really aiming for that professional-level grasp of the essentials laid out here.
And I think delving into this level of detail, following the source's systematic approach, definitely moves us in that direction. It
Yeah.
provides such a powerful framework for understanding visual symptoms and the precision needed in this field.
It truly highlights how much the eye reveals about our neurological state and general health.
Absolutely. It's a remarkable window into the body and brain.
So, a final thought for you, our listener, to maybe mull over. Next time you notice something about vision, maybe your own, maybe someone else's, even simple things like how their pupils look or the way their eyes move, or if they seem to miss things in their peripheral vision. Consider that these might be subtle clues. Clues reflecting those deep, complex connections within the body that we've explored today, all revealed through the intricate workings of the eye.